So today, my first appointment of the day is actually an infant, a newborn, and we're going to be testing the hearing of this newborn. Many people maybe don't know that you can actually test the hearing
Well,
of
wait
a
a
newborn
minute.
baby.
I got to pause you. I thought hearing loss was just kind of like as we hit age 50 and older, our hearing kind of slowly starts changing when we become of age.
Sometimes you think of it as an old person thing.
That's right.
Yeah,
so
no,
it is true.
It's true. You can have hearing loss as an infant, as a young child. In fact, with hearing tests, we tend to test hearing later in life and very early in life.
That's when
we usually test.
These are the patients we see are the newborns and the very young little ones. And then we see kind of that age 45, age 50 and older. Those are, we see the distal ends. We don't always see a lot of people in the middle. That's true.
And this might be surprising to people to think, wow, you can test a newborn baby? You can test an infant's hearing? We want to talk about that here a little bit today, so keep watching. It's a crazy idea, right? Because when we do a normal hearing test, and many of you probably had hearing tests, you hear a beep, and you either raise your hand or click a button. I like to joke sometimes we've advanced from hand raising to button clicking over the last 60 years.
Button clicking is way more advanced.
Button clicking advanced. But can the newborn baby do that?
So interesting. You know, when you think about the importance of acquiring language and the ability to be confident as you go into your preschool and kindergarten and you start your journey down this academic sequence of I need to build upon what I'm learning each year, the very basic tool of doing well in school is you've got to be able to talk. You've got to be able to speak English. And to be able to speak starts with the reception. You have to be able to receive a language before you can express, right? And so hearing and being able to receive language and be able to just understand that process is so important. And so it's so important that in all 50 states, it is a law that your infant, when the infant is born, within the first month, and they try to do it within the first days, even the first, I would say the first probably 10 hours of that child being born, that baby is going to have a newborn hearing screening.
Yeah, and this might surprise people to know that this has been going on for a long time. They've actually been doing this since the 80s. Isn't that right? Isn't that when this started rolling?
Yeah, and I think even like most states had it as a law, even as early as like 2003, 2004. Like it's been in place for decades.
And now and now it's law. All 50 states do it. So how in the world do you test a newborn baby that's 10 hours old? How in the world do you test their hearing?
Start with the screening at the hospital.
Yeah, so the first thing that happens at the hospital, and parents that have had children, you've probably been through this. There's a lot going on though when a child's born. So oftentimes you forget one thing or another, but when your child's born, you usually have to sign a little document saying you're allowing the hospital or someone that's contracted with the hospital to screen the hearing of your child. And they come usually into the nursery where lots of the infant newborns are. And they run a test called an otoacoustic emission or an ABR.
That's right.
I think we'll talk about both of those.
That's right. So what happens essentially is most hospitals have these little cups. They're little small cups because babies' ears are not like mine. They're not quite as beautiful and big, but they're just teeny. And so they have these little cups and they put them right over the ear and they will introduce a small sound. And the sound that they introduce is usually called a pip or a click, or it's just a little popping sound, kind of a clicky sound. And essentially the sound goes in the ear and it's a little, sound wave. It pushes on the eardrum and it puts your auditory system in motion. So much so that these little hair cells will contract. And most of that energy, of course, goes towards the auditory nerve and up the brain, but there is a signal that comes in reverse. It's an otoacoustic emission. It's like a little wave, almost like an
echo, right?
Like an echo coming back, and it puts the signal coming back towards the eardrum, and the little probe that's in there picks up this echo. And if it picks it up and it's a certain size or it has a certain energy to it, it will count as a pass for that frequency, and it just kind of moves through the different tones or frequencies. And really, we don't know how well the child is hearing perfectly because it's just a pass or fail system. But typically, if your little baby can pass a newborn hearing screening, we all feel really good about that child's development ability is probably going to be on track or have the ability to be on track because their ears are working. You know, if a newborn fails, like what do I do if my child fails? What happens?
Let's talk about it.
You know, basically the hospital takes note of it, and then they will, with their nursing staff, they'll document what happened and on the date and which frequencies passed, which ones failed, and overall it's just usually a pass or fail for us is what we see. And so then they will contact a doctor of audiology group like ours or another one, a group that has equipment to do more of a comprehensive test, maybe a little bit more of an in-depth look at how this individual's hearing really is. And so now we're going from a screening to we're going to try to get really specific and really try to drill down, or not drill down, but really try to figure out which areas of this individual's hearing ability, which frequencies and which pitch tones might not be working right and which ones are. And the good news is if your child has not passed recently, or your infant, or maybe you know someone, the good news is most of these cases that get sent to us, and usually we see them within weeks. So just the child's gone home, and within weeks we're trying to see them because we're trying to get, if a child has hearing loss, we want to know about it. We want to start getting them, remediation. We want to start figuring this out as quick as we can. We may even need to employ like a treatment plan quickly. But the great majority of infants who have failed at the hospital, they actually pass once, a couple of weeks has gone by. Maybe it's been 2 or 3 weeks since their initial screening. A lot of times just the way the amniotic fluid and the way the congestion and just this everything about the child, just that little bit of maturation in that short time frame, the different things that work out, a lot of them pass.
Definitely. So
you know what I mean? So
don't
that's
get
good.
too worried. It is just a screening that they do at the hospital, and it's a cool little screening, and it is very accurate, and child, the baby doesn't have to respond. Yeah. But if you're a parent that has a child that failed the screening in the hospital, don't get too concerned yet because many of them do pass a subsequent test.
That's right.
And maybe just as an interesting side note, kind of along these same lines, a discussion of why would they fail. They might have a little bit of this fluid in their ear canal.
Yeah.
They might have a little bit of fluid still behind their eardrum.
That's right.
And any kind of fluid in the ear canal or in the middle ear will prevent them from passing this test.
Kind of give them an artificial hearing loss. Yeah. Just a temporary problem.
And minor, probably. Another possibility is these are very delicate little measurements. And if the earpiece isn't quite right on their ear, or if the environment's a little bit noisy, sometimes the test just isn't administered perfectly.
It can be technical.
It could be a technical issue. So if that's the case for you, it is a good idea to get your child tested, but don't get too worked up just yet.
That's right. So what happens when they see us? What do we do that's a little bit different?
So typically what we'll do, I will usually repeat this otoacoustic emission test because after a couple weeks...
Well, even before that, we have these special tips, these special little speculum tips where we can actually look in their ear and look for a foreign object that may have caused the issue to begin with. So even just starting with a good otoscopic check with special tips that are built for infants, that's taking place.
Just look in the ear, right?
And then you keep going. Yeah.
Repeat the test.
Yep.
There's tympanometry that we can perform. This is a test that can detect fluid behind the eardrum. So if we look in the ear and we see a foreign object or we see fluid, it's pretty obvious to us. But sometimes you can't see beyond the eardrum very well. And so this test of tympanometry, it puts a little pressure against the eardrum, and we're able to measure if there's any fluid buildup behind the eardrum. And if we see some fluid behind the eardrum, it's kind of an aha of, here's why they're failing this other test.
We caught it.
We got it. I mentioned at that point we usually repeat the otoacoustic emissions.
That's right, the OAEs.
Let's repeat it because oftentimes they'll pass after a couple of weeks. But then let's talk about this other test. We also run a test called an ABR, an auditory brainstem response test.
That's right.
That's a pretty cool test.
That's right. So an ABR test deals with the electricity that comes from our skin and from our organs. And so when we move our eyeballs, it creates electric motions that go up your optic nerve or your ocular motor nerve. Well, your auditory nerve, there's an auditory nerve that comes into our cochlea. And the cochlea, as Dr. Whitaker was saying, have these little cilia, and they move with motion. And when they move, they kind of deflect one way or another. And when they deflect, it creates an electric impulse that goes up the auditory nerve. And what we're trying to do is we can put electrodes on the ear and in different areas on the face that help us figure out if this individual has enough energy flowing up the nerve. So now we're not testing, say, hair cells indirectly. We're kind of testing the auditory nerve to see, is there appropriate energy that's going up the nerve and up into the brainstem? We don't really test to see with an infant if the signal got all the way to the brain because, again, they can't respond. They can't tell us that they heard a sound. So that would involve ear all the way to the brain. But we can actually get information from the ear all the way up through the brainstem with these little electrodes. And so reading the electrical currents that come from the auditory nerve, and consider that there's five different areas where the sound will go and be analyzed, and then it goes to another area called a neuron, and then it goes to another type of neuron bundle. And these little bundles kind of organize sound. Well, we know exactly, based on testing lots of infants that have normal hearing, we have this normative data across the entire country and actually across the entire world of what an infant between the age of 1 week to 3 weeks, what their response should be, and then 4 weeks to 6, it is organized exactly how an infant should respond, how the electrical activity should respond to these corresponding bundles at every age of their development, even up till they're an adult. Like adult norms are going to be different than brand new infant norms. And so the normative data that we have available for us with our equipment, we can see exactly a small region of where they should be at, say, a wave 1, a wave 2, all the way through wave 5. And it helps us know how they're doing at each frequency. So like a lower bass tone, and then like a normal right in the middle of the piano, like a middle C, 1,000 hertz, and then maybe even a higher, like a 2 to 4,000 hertz. We can test each of these frequencies and know how that child's auditory nerve is reacting to sound. And if, of course, that goes well, and the OAEs have gone well, and the tympanometry with how the eardrum is going well, and there's no fluid, we, of course, can send that information back to the state of Utah or whatever state we're in, Nevada or whatever. And we can also talk and counsel with the parent at that point and say, hey, your child's doing great in both ears, or whatever the situation may be.
Yeah, the ABR, it's obviously a little bit of a technical test, lots of technical terms, but I like that in a very general sense. We're playing a sound to the baby's ear.
Does it hurt?
It doesn't hurt at all. It's a little tip in the ear,
Super
painless.
invasive, yeah.
The baby's nerve responds. The baby's nerve is sending signals up through the brainstem, and we're able to measure on a screen the baby's neurologic response to these sounds. So what we see on our screen is a wave. We see on a computer screen a little bump, and we say, when I played that sound, the baby heard it. We can then turn it down a little bit. We can play it again, say, did the baby hear it quieter? We can verify that they did. Yep. We can test different tones, different frequencies, and we can essentially run a hearing test without the baby responding, just by looking at little waves on our computer screen and seeing if the ear is working. And if your baby does not pass the test, let's say we do a hearing test, we do an ABR, and your child happens to have a hearing loss. Mm-hmm. If the hearing loss is profound, meaning that there's just really no signals being detected in the nerve, typically at that point, we would refer on to somebody who handles cochlear implants. And cochlear implants are a really cool option for young infants without hearing. We won't get into cochlear implants in too much detail, but suffice it to say, this is an implanted device that can restore hearing in an individual that has no hearing.
And what we found, and what the surgeons have found, what the research shows, is that the early detection and the early intervention, so getting some kind of sound to that baby's brain as soon as possible. And our goal is obviously the first 3 months of their life, but if we can even help someone, say, in the first month or month and a half, it's pretty impressive that us being able to truly know and understand their behavior, their function level, by the time they're a month out or a month and a half out. That's always the goal, is to try to figure out what's going on with this child as soon as possible to give that child the best opportunity to develop properly and to be confident in society and things like that.
Yeah, and not every child will need a cochlear implant. Some children or even infants will wear hearing aids. So there may be some degree of hearing loss.
Yep.
And it is possible to fit infant babies with hearing aids.
Yeah.
And like Dr. Lukenge here said, it is critical to get that child hearing or to be stimulating the auditory system as early as possible.
Yep.
So this early intervention within the first few months of life is really important, and we definitely encourage that.
Yeah. So we hope if you've had questions along the way as you've listened to this video, you're welcome to respond. Just make a note there, reach out to us. But we hope this video has been of some help to those individuals who have recently had a child, and maybe your child didn't pass the newborn hearing screening, or maybe you were taken back that, oh, they do a hearing test and what's this about? Hopefully this video has helped. Okay, everybody, we so appreciate you watching the video today. If you've liked what you've seen, please like it, subscribe to our channel. It means the world to us, but it also means the world to other people who are trying to figure out what's going on with their hearing health. So thank you for watching.